will focus on what we understand about the hemodynamics of septic acute kidney injury. You cannot study the hemodynamics of the kidney in human beings. They require invasive interventions to measure renal blood flow continuously, to measure renal oxygenation, renal vascular resistance, and flow distribution within the kidney. And so you have to go to experimental animals. In Australia, we have 110 million sheep, so the sheep is the favorite animal. They're very, very easy to handle. They don't bite you. They're very relaxed, very easy. They're about 45 to 50 kilograms, and you can really do lots of things. And this is one of the sheep we do instrumentations of, and you can see lots of flow probes and measurements. They can be allowed to download data every heartbeat and measure a variety of variables that are relevant to sepsis. You can then induce sepsis in a variety of ways. Our favorite ways to give gram-negative bacteremia to animals. And we've got an E. coli, which was isolated from a human being with gram-negative bacteremia. You inject it at the appropriate dose, and then you induce sepsis in the animal. You can see that over a period of time, there's instability of blood pressure and cardiac output and heart rate. And after a period of several hours, you have what we typically see in human beings, which is a hyperdynamic septic state with a high cardiac output, tachycardia, and hypotension. And you have oliguria, rising serum creatinine, high lactate. The animal is febrile, temperature usually about 41 degrees. They sit in the cage, they look unwell, they're tachypneic, they look very much like a sick person. The difference, of course, is that in the sheep we can measure renal blood flow every heartbeat. And I'm just representing it with 5-minutely data here. And you can see that whether you give norepinephrine to maintain blood pressure or you give placebo, what happens to global renal blood flow using a renal artery flow probe is an increase in renal blood flow. It's quite dramatic. It's of the order of about 150%, and it persists after gram-negative bacteremia for up to 24 hours. And it is due to an increase in conductance, which is the inverse of resistance. So there is renal vasodilatation, or a decrease in the resistance to blood flow to the kidney, which is responsible for the increase of renal blood flow. But please let me reiterate this. This animal is almost anuric and has a rising creatinine. So you have functional loss of kidney function, but you have increased renal blood flow. So in this experimental model of gram-negative bacteremia with acute kidney injury, we have an increase in renal blood flow and a decrease in renal vascular resistance, so that in experimental gram-negative bacteremia, there is acute kidney injury due or associated with hyperemia, which I'm sure is very different from what you read in the textbooks. So why would you get, what would be the mechanism by which you would get an increased renal blood flow? Well, if you believe what they tell you in the textbooks, that the glomerular circulation is the end point of the renal circulation, there is only two ways that you can have hyperemia. Either the afferent arteriole dilates, but if that's all that happens, you might have a decrease in resistance, but if the efferent doesn't change, that's not going to work. So the efferent has to dilate as well. So you have to have afferent and efferent dilatation. But if that's what you do, then you're going to have increased renal blood flow to the glomerulus, and you cannot possibly logically expect a loss of GFR. So for that loss of GFR to happen, you have to decrease the pressure in the glomerulus, which is the filtration pressure. And for that to happen at the same time that you have hyperemia, this has got to dilate, and this has to dilate even more, so that the pressure inside the glomerulus falls. So if this is the thinking, that the hypothesis as to why there is vasodilatation and loss of function in the kidney, then the logical expectation would be that if you gave a vasoconstrictor, you would potentially have a reversal of this physiological state in the animal. And you can do that with a selective efferent vasoconstrictor like angiotensin II and test the hypothesis that this might be true. So this is the sheep with sepsis, and you have hypotension, and you have correction of hypotension with angiotensin II infusion compared to placebo, cardiac output, and the heart rate and the total peripheral conductance changes are as expected from a vasoconstrictor. And if you do that, as you would expect when you give angiotensin II to these vasodilated animals, there is a decrease in renal blood flow because you've constricted the efferent arteriole. That's not a surprise, it's well established. And this is the change in conductance, which is the inverse of resistance, showing that there is increased renal vascular resistance due to angiotensin II. What you might find surprising, however, is that in these animals, when you give angiotensin II instead of placebo, despite the fact that the renal blood flow has gone down and the vascular resistance has gone up, there is a pretty dramatic increase in urinary output. So the order of 5 to 10-fold increase in urinary output. And when you look at the creatinine clearance that has decreased in the animals, there is a much faster recovery of clearance with angiotensin II and a lesser loss of clearance and a loss of function with angiotensin II compared to placebo. Do we have any other data that other potential less powerful but nonetheless able to induce efferent arteriolar vasoconstriction drugs might also affect the function of the kidney in sepsis? Well, AVP is another such vasoconstrictor. We've studied that in our experimental model, and you can see again that there is a change in urinary output with AVP compared to control, but it is relatively short-lived, and it is not as powerful as that achieved with angiotensin II. So we've got some data that vasoconstrictors that are relatively selective or totally selective for efferent arteriolar vasoconstriction appear to help renal function in gram-negative bacteremic acute kidney injury. Does this happen in man? Do we have hyperemia in septic human AKI? Well, in order to know that, you'd have to measure renal blood flow, which is only possible with the technique of para-aminohippurate, and that requires renal vein sampling in the setting of acute kidney injury, which requires invasive measurements. But nonetheless, some similar experiments were done in the 70s. This is Lucas and the Archives of Surgery, 11 patients with intra-abdominal infection, and what they found was that total renal plasma flow was 154% of normal in these septic patients. And indeed, there is some volunteer work with pyrogen in the 1960s also supporting the view that there is vasodilatation and increased blood flow during sepsis. And if you go back to the literature to the 1940s, to the work of Homer Smith, the doyen of nephrology in the United States, and you look at diadrast clearance, you can see that there is a significant increase in renal blood flow with the infusion of pyrogen in human beings. What about modern data? We have some data to suggest that vasopressin might affect kidney function in septic shock. This is post hoc analysis of patients with early acute kidney injury treated with vasopressin as opposed to noradrenaline alone, showing an attenuation of renal dysfunction with the use of vasopressin, and it may be an effect on survival in this subpopulation of patients. More recently, Tony Gordon conducted a VANISH trial where, again, the hypothesis was tested that the addition of vasopressin might have beneficial effects. There was no clear effect on creatinine and urinary output. However, there was a signal in terms of use of renal replacement therapy in favor of the administration of arginine vasopressin, providing low level but nonetheless suggestive evidence that a vasoconstrictor such as AVP may beneficially affect function in septic acute kidney injury. Some of you might be aware of a randomized controlled trial that has been recently completed of angiotensin II in patients with shock. This was completed in November last year, and the top line results were recently released to market of the ATHOS trial, providing information of the vasopressor effect of angiotensin II, and we will just have to wait for the final report of the trial in relation to the renal function. But this dissociation between function and flow may be more complicated than we think, and there may be more to it than just efferent arteriolar vasoconstriction. When you look at the literature on the glomerular circulation, you find that at least in two different species, the mouse and the rat, in the cortical glomeruli, the anatomy of the kidney on electron microscopy is not what we're told in the textbooks. Namely, the afferent arteriole can go directly to an afferent vein and completely skip the glomerular circulation, so that you have pathways that anatomically would allow shunting away from the glomerulus. Does that happen in septic acute kidney injury? Go back to the sheep, and you look at the assessment of cortical and medullary perfusion and oxygenation in septic acute kidney injury. When you do that, in the model that I showed you, you see that even though cortical tissue oxygenation measured directly by oximetric probes is preserved, and cortical tissue perfusion is preserved, medullary perfusion using laser Doppler flowmetry and medullary oxygenation using oximetric probes actually falls. So there is a dissociation of flow and oxygenation of the cortex versus the medulla, even though you're seeing a global increase in renal blood flow. And that's associated with acute renal failure, as I was describing before, with a rise in creatinine, a fall in creatinine clearance, and a dramatic decrease in urinary output. So blood flow is up, but there is intrarenal dissociation in terms of oxygenation. So even if we knew the global blood flow, and even if we knew something about the intrarenal blood flow distribution, there is a significant dissociation between the cortex and the medulla, which is associated with loss of function. Does anything like this happen in man? What do we know about human beings with modern technology? One way to look at it is to use the technique of phase contrast MRI, which allows you to measure renal blood flow. And when you do that, this is a cohort of septic patients in the ICU, mechanically ventilated, taken into the scanner to make such measurements. You find that there is a clear dissociation between the renal blood flow, global, as measured by phase contrast MRI, and the creatinine clearance. So you can have high flows and low clearances, medium flows and relatively preserved clearances. So renal blood flow is dissociating from function in human beings, just like it is dissociated from function in sheep. So the global blood flow in sepsis may initially be high. What drives the degree of vasodilatation is unknown, but they may be a combination of shunting and efferent vasodilatation. Human data, as best as we can ascertain it, shows that global blood flow and function are actually dissociated, and we have histological data to show that there are very few histological changes, so maybe even the histology is dissociated. That may be due because there is a loss of filtration pressure in the glomerulus due to shunting, and most of all, knowing about the macro circulation, which is what we deal with, may not be enough, because acute kidney injury may well be a disease of the microcirculation. And if that's what it is, then we're so far away from being able to manipulate it. And we'll see if the administration of angiotensin II in the ATHOS trial delivers any signal. Thank you very much.